Many patients will actually do really well with a male sling. I think there are a couple factors that make it important for men to realize, hey, this is where a sling's appropriate, or where maybe the sling won't meet their needs. For men that leak a lot at night, the sling won't necessarily take care of that. For men that are leaking during the day where they get the urge to rush to the bathroom and they leak on the way to the bathroom, the sling won't necessarily take care of that. Or men that are just leaking constantly, where they can't hold the urine in at all, the sling's often not as effective at treating that. Other than that, however, many men do really well with the sling, and the sling does give them that strength and that confidence back that they are going to be able to control their urine when the time is right. The patient who does have some ability to stop their urinary stream, the patient that is leaking primarily with a full bladder, or when they lean over or cough or go to tie their shoes, those patients are going to do really well with the male sling. In the vast majority of cases, insurance does cover the male sling. The insurers may not cover the pads, they may not cover the clamps to use, but typically we are able to get insurance coverage for the male sling, and Medicare does traditionally cover the male sling as well. There are two main types of male slings available currently in the United States. One type is a two-armed approach, which provides elevation of the urinary tract trying to support the muscle that's there. The second type is a four-armed approach. And with the four-armed approach, you still have the two arms that will actually elevate and support the urinary tract again, supporting that muscle, the external sphincter muscle. But you've also got two arms that then actually provide some compression and will help to support that even a little bit further. Determining what's right for you, which is the most important aspects in your particular care, is where seeing a specialist can really make a difference. The sling is made of a polypropylene mesh, and that's important because the mesh component of that is what allows the body the new tissue growth that's going to occur to grow into it and help really support that sling, holding it in place. So it's not just the sling being in place, but our body's response and how our body heals it that gives us the best outcome possible when we're looking at the male sling. The male sling is implanted in a surgical procedure done in the operating room. For most patients, it's a procedure where they go home the same day. With the patient asleep, we put the legs up in stirrups, and the incision is going to be created in the small area between the scrotum and the anus, where you would typically sit on a bicycle seat. A catheter is inserted, and this is done after the patient's asleep and removed prior to the patient waking up. We carry down our incision, finding the urethra, particularly the bulbar urethra, and elevate this area to provide support for the external sphincter so that when patients do cough, sneeze, and laugh, they have extra support where that is not going to generate a pressure that allows urine to leak out. Once we are happy with how everything's sitting in place, we will actually close the incision in several layers, with the skin layer being closed with an absorbable suture followed by skin glue that's placed as well. The patients are subsequently awakened, taken to the recovery unit, and as long as they're able to urinate prior to discharge from the recovery unit, a catheter is not inserted and the patient's able to go home. The male sling works in the body through two primary mechanisms. The first mechanism is that the two initial arms, what's called the transobturator arms, are used to help pull the bulbar urethra, or one of the more thickened portions of the urinary channel, up to help re-support the external urethral sphincter. Now that's important because one of the things that happens, particularly following prostate treatments, is that with removal of the prostate in particular, there's a little too much movement of that area, and the external sphincter needs a little extra support to be able to help really hold that urine in. So initially, we are re-approximating and helping support that external sphincter with the transobturator arms, and then the other two arms are used to provide a compressive effect. That compressive effect helps further bolster so that when patients are coughing, sneezing, laughing, that it's not enough of a pressure to actually push the urine out, However, when they do go to the bathroom, generate a good bladder pressure, that is enough to make sure the urine completely empties, passes out, and kind of resets to help patients be as dry as possible. How long a male sling lasts is variable, and some of it depends on how dry the patient desires to be. Over time, we can see that the male slings are not as effective as they initially had been, particularly if there's neurologic changes or changes to the external muscle, which makes it less likely to be effective at squeezing and helping hold the urine in. However, for most patients, they are getting a solid 5 to 7 years of very good urinary control, and for other patients, they can even go beyond that with good urinary control, often again dependent on patients' overall health. There are a number of studies in the medical literature that suggest male slings are an effective treatment for stress urinary incontinence. Now, as we've discussed in some of the previous questions, it's important to make sure we know exactly what we're trying to address, what we're trying to improve, to make sure we can truly define what is an effective outcome. These studies have been done and rigorously tested. Additionally, with experience, even some of the data that's not been reported, we've been able to identify pathways that will make sling placement even more effective than what it would have been in the past and how we had done it in the past. One of those such methods is actually fixating the prepubic arms of a 4-armed sling to the pubic bone. And by doing so, we help provide more support and less likely a chance for that sling to loosen a little bit and decrease its effectiveness. As with any surgery, there are risks to sling placement. One of the most common risks for that would be urinary retention. Thankfully, we do not see many men go into urinary retention following surgery, at least for not prolonged periods of time, meaning over 2+ weeks. The majority of men, even if they have urinary retention early on, with a week of having a catheter in place, will be able to start urinating on their own. There are rare cases, however, where we have not identified that the patient's bladder is not squeezing as strong as it should, and therefore placement of the sling may actually lead to prolonged urinary retention. The sling also is passed through a couple areas where we can see irritation of nerves or even a bit of a hematoma or blood that's pooled under the skin. That blood may be a short-term issue where it resolves and doesn't lead to any prolonged discomfort. Other times, if there actually is nerve root irritation, we can see patients complain of discomfort in one or both testicles or discomfort in the hips for a period of time following surgery. Finally, there is always a risk of injury to any of the other structures we're working around, whether that be the urinary channel itself, even the corpora where blood will actually flow to help guys get an erection. And again, having a specialist, someone who does this routinely, will help minimize that risk for patients.